Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Al Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
We are excited to be sitting down with Dr. Ayesha Zia on the management of pulmonary embolism in children. Dr. Zia, please introduce yourself. Tell us who you are and what you do.
Thanks so much for having me. I'm Ayesha Zia. I'm a pediatric hematologist and a professor of pediatrics at UT Southwestern and direct the Hemostasis and Thrombosis program here. My clinical research focuses on pulmonary embolism, how we diagnose it, treat it, and then support children after they have recovered from a PE.
Oh, well, that's wonderful. Dr. Zia, we're so excited to have recruited you to this episode. And I would like to say that Zach highly recommends your October 2025 How I Treat Pulmonary Embolism article. So we'll link that in our show notes. Before we move forward, do you have any conflicts of interest to disclose?
Yes, I've served on advisory boards for Sanofi, CSL Behring, and Star Therapeutics, but these relationships are unrelated to the content of today's discussion.
Excellent. Alice, do you want to give us our case and our first question? We'll get going.
Let's do it. All right. So you are seeing a 15-year-old female gymnast. She's presenting to the ED with a 2-day history of chest pain that is worsening. She also has left leg pain that she attributes to an injury while practicing. Medical history is unremarkable, except for the recent addition of OCPs for heavy menses. On exam, she is tachycardic, tachypnic, and has left lower leg swelling. So we've given you a child with many of the common nonspecific risk factors of pulmonary embolism, including chest pain, OCP use, leg swelling, and what sounds like maybe some DVT symptoms. Other common risk factors include shortness of breath, recent surgery, and history of blood clots. But what findings on history and physical exam do you feel are most commonly missed or kind of like misinterpreted in your patients who eventually end up having a PE?
Several things are often overlooked in children. And I feel like this is such an important question because PE overall is missed in the emergency department and often on the floors. I know you mentioned she had tachycardia, but one of the biggest things which we miss is persistent tachycardia. So I think we're quick to attribute that to pain, anxiety, sometimes when it's a female, dehydration. But in PE, persistent tachycardia may be the only early sign of cardiopulmonary strain. The second, I would say, is leg pain or swelling. Again, in the context of when you're dealing with the athlete, because it's often labeled as musculoskeletal injury, and that can often be the clue to the concomitant DVT that an athlete has. And lastly, I would say syncope, dizziness, or even near syncope that may be dismissed as vasovagal events rather than a marker of impaired cardiopulmonary reserve. And the other thing that's so different in pediatric PE than in adults is a normal blood pressure. See, normal blood pressure does not mean that the child is stable. A child can be in shock, not that I have to explain that to intensivists, but especially in the context of PE, children can be in shock with preserved blood pressure. And I think that's a huge pitfall.
Oh, yeah, because you're probably the one, I imagine, reviewing these cases, whether it's your PERT team or you're doing M&Ms and looking back at the vitals. Persistent tachycardia.
Yes.
You know, we have the opportunity in the ICU that when people land there, someone else has already looked at that child and deemed them to be sick. And they've come to the ICU. So, the pretest probability is going to be much higher. They have bad things like pulmonary embolism. But still, I feel like we miss it. And I think that we should think about pulmonary embolism more in kids. And it's one of these things on my differential diagnosis that I think about when I can't explain a persistent tachycardia. And I think that's worth hammering home here today. And I also wanted to emphasize that you don't have to have hypotension to have a real hemodynamically significant pulmonary embolism, and we can talk more about that later.
Yes.
So when caring for a child who has these risk factors for PE, but there's diagnostic uncertainty like there is really commonly, is there a clinical criteria that we can use to effectively rule out pulmonary embolism in children?
At this point, no. We really do not have any validated pediatric equivalent of Wells, PERC, or Years criteria that adults so commonly use.
What about the D-dimer? Now I want to send a D-dimer on all of my teenage girl athletes.
You see, a D-dimer, especially when it's negative, can be reassuring in a low-risk child. So, there are peaks in PE. So believe it or not, you can see PE in neonates, especially in those with congenital heart disease. And then the second peak is your adolescents. And so if you think about 6 or 7-year-old, that's not a common age for a PE in an otherwise healthy child, for example. So in a low-risk child, a negative D-dimer can be reassuring. But, from my vantage point, it cannot be used in isolation to rule out PE. And D-dimer is frequently elevated in kids due to, the usual, the infection, inflammation, trauma. And its negative predictive value is not really established in pediatrics.
Now, are there things in the works about trying to find a clinical pathway or clinical criteria to rule out PE? When I was preparing for today's talk, I found something called the Beeper study. What can you tell us about that?
Yeah. Believe it or not, I wrote a note to Jeff Klein, who's the overall national PI of the Beeper study. I know the results were presented in an abstract in May last year, and it is essentially trying to answer this question. Adult tools will rely on epidemiology, age, and such, comorbidities, and some vital signs that to diagnose PE, but they do not translate cleanly to children. And the way I think about pediatric PE is it's rarer, it's often more provoked, and will occur in a population that has a very different baseline risk than in adults. So I think we have to wait for Beeper results. What is exciting from the abstract that's published is that PE is actually more common than we know it to be. And in the Beeper study, I'm trying to remember, it's across 20 or 21 children's hospital, 2,000 kids, and PE rates were 4.2%, which is essentially approaching the 5 to 8% diagnosis yield for adult PE in adult EDs. And so the take-home message is that it is actually more common than we believe it to be.
Wow. Was that emergency room patients or admitted patients or
emergency room?
Wow. That's wild. That's very unexpected.
Yeah. So, we'll see. I didn't get a response from him, but we'll see what he says. It should be coming out fairly soon.
Excellent. Alice, you want to remind us of our case and give us an update?
Yeah. So we've got a 15-year-old girl who's here for chest pain, found to be tachycardic, and also has a history of left lower leg swelling. Assuming that she's hemodynamically stable, although I definitely have questions about her heart rate and maybe how her RV looks, what are the immediate next steps? Say we get our CTA, it shows that she does have a pulmonary embolism.
This is an important point that I will emphasize throughout our discussion. I think first and foremost, start anticoagulation promptly. We at our institution and many others will initiate IV heparin, mostly because it's rapidly reversible and easy to titrate. And then at the same time, we assess severity. And that includes an assessment of hemodynamic status, cardiac biomarkers like troponin, and echo to evaluate the RV.
Wonderful. Now, troponin, brain natriuretic peptide, easy to send. I'm adding them on. I'm sending those labs. Echo is a little tougher because you might call someone who says, stop being so dramatic. I don't want to echo this patient. Does the location of the PE on the CTA push you in one direction or the other? If it's a small distal and she's not tachycardic, would you let them say no to echo?
I think we are lucky at our institution that we have the PERT. And if we have activated a PERT, then through that, the cardiology fellows, for example, at our institution are sort of bound to some timelines and a protocolized way of doing this. But I agree with you. I think if the RV-LV ratio is normal, less than 0.9, less than 1, we're establishing that threshold with some ongoing work. And it's peripheral, subsegmental, maybe we weren't even expecting it. It's hard to push for that. In those cases, what we have done is if everything else points towards a low-risk PE, which obviously you need an echo to say that a patient is low risk, but everything else is low risk, and we have allowed the echoes to be done first thing in the morning, for example. But it is hard. Generally, when PERT is activated, we are lucky that we get it done.
Yeah, the pulmonary embolism response team, it sounds like it's both a neat way to collect and systematically assess these cases, but also a good safety block, right? Is the LV to RV ratio, are you talking about on the CT angio?
Yes, our radiologists, if it's a CTPA for PE, they will usually have a comment in there, no evidence of RV strain. And if there is a PERT activated, then they would actually on the CTA while either the echo is being done, but maybe the patient is sick and we got together as a group, they will immediately give us the RV-LV ratio on the CT as well.
Oh, interesting. I feel like my mental model was that because they're not syncing the scan with systole or diastole, you can't trust those numbers like a cardiac CT. But it sounds like it does have some value.
Yes, I think it does. The only thing I would mention is that, well, is there correlation between the CT-RV-LV ratio and the eventual echoes? We have seen that sometimes they don't correlate. And for us, we still consider echo as the gold standard.
Got it. Okay. I have one more follow-up question. If it looks like a distal vessel, could I convince you that it's okay not to echo if the brain natriuretic peptide and troponin were negative? What do we think about the sensitivity of those biomarkers?
Yeah, I know we'll get to the risk categories, intermediate and high risk. So within intermediate risk PE, there are two categories, intermediate risk high and intermediate risk low. So if the troponin or BNP are normal, then without having the echo, I know this is not going to be intermediate high, which is where we tend to intervene and maybe do something beyond anticoagulation. So maybe distal troponin is stone cold normal, child looks clinically okay. And you also, there's a little bit of a gestalt to it and the gut feeling as well. Everything screams like it's a low risk, then we may agree with either cardiology or ED as to, hey, can we push the echo?
Well, this is awesome. Okay, so let's get back. Let's say I'm coming to you, maybe I'm new to UT Southwestern, and I'm like intermediate high risk. I thought it was submassive and massive PEs. What are intermediate and high risk?
Yeah, so I think this is really driven by the adult societies that developed these parallel frameworks. So massive, submassive is by AHA, American Heart Association, whereas your low risk, intermediate, and high risk categorization, that was more coined by ESC or European Society of Cardiology. In pediatrics, we tend to use intermediate and high risk because those terms sort of align more directly with the management decisions.
Let's go ahead and unpack how you determine if a pulmonary embolism is high risk and how you determine if it's intermediate risk. Let's start with high risk.
Yeah, so high risk includes certain features or combination features. Obviously, you have the objective presence of PE on imaging. But in addition to that, if you have sustained hypotension, cardiovascular compromise or collapse, you're already on pressors, and obviously a shock state, then those patients are categorized as high-risk PE. They have the highest mortality risk and require urgent reperfusion considerations.
Oh, yeah. Do you know, is there a mortality risk that's quoted?
This is where we often will look at adult data. I think about maybe a 17 or 18-year-old. I do feel comfortable applying the sort of the adult evidence that's out there. So in adults, high-risk PE carries, the mortality is striking, often around 30 to 40% at 30 days, whereas intermediate risk, it's more like 6 to 8% at 30 days. I think in children, we have overall mortality for PE, which is around 8%, but we really don't have, at least yet, large pediatric data sets that can reliably break mortality down by our adult type high risk or intermediate risk PE.
Oh, got it. And if you think about, we quote general PICU mortality, like walking into any unit, your mortality should be around 2%. And so automatically it sounds like having a PE makes this one of your sickest patients.
Right.
I wanted to emphasize that you diagnose or you classify a PE as high risk primarily based on clinical features. So hypotension, shock. In kids, you can have tachycardia without hypotension as long as there's evidence of shock. That might be an elevated lactate, a low central venous oxygen saturation, poor peripheral perfusion. I want the focus to be on the patient and not necessarily on always thinking about what the labs and the imaging shows.
Yeah, I totally agree with that.
Let's pivot to intermediate risk PE. How do you determine if a child is intermediate high and intermediate low risk?
So intermediate high risk is when you have obviously a PE, and along with that, you have RV dysfunction or strain and elevated biomarkers. But intermediate low is when you have either of those alone. So either RV dysfunction or biomarker elevation alone. So one or the other.
Okay. It's almost like an RV definitely impacted versus RV probably impacted.
Yeah, that's a neat way to think about it. And, now we have established our PERT and we've been formally risk categorizing. And then really after the patient is out of the hospital, reviewing those cases, I tend to put the intermediate low more towards the low risk and intermediate high more towards the high risk category. And the first 2 years of our PERT implementation, we activated PERT on all intermediate risk PEs, whether intermediate low or high. But as we've gained more experience, I haven't done this now, but I am leaning towards not activating PERT for intermediate risk low category, which in our institution so far, we have really treated with anticoagulation alone. And I feel like when it's anticoagulation alone, perhaps I don't need to get the 10 subspecialists together on a call in the middle of the night, for example.
Oh, yeah. Wait, so can you tell me about the 10 subspecialists in your PERT team?
Yes. Our core pediatric PERT members generally include hematology, and hematology is the leader of that call and conference, critical care, interventional cardiology, interventional radiology, emergency medicine, anesthesiology. And if PERT is activated during the day or work hours, then we have our anticoagulation pharmacist join the call as well.
Wow.
And so these are the core members. And then in addition, if the PE was on a floor patient, then the primary service will also join. We have not yet figured out a way how to incorporate parents into the call as well.
Wow.
Yeah, it's fascinating. I will share just being on the ICU side of things, like how I've generally seen this. And Dr. Zia, please feel free to jump in if this was something atypical. But like you have that patient who is diagnosed with pulmonary embolism. We usually call the hematologist on call. Usually it's the fellow. And they trigger this PE response team. It was done with us over Zoom, and I thought it was pretty well done. I mean, the fact that we can get, this complex medical decision-making done, at 6 o'clock, 7 o'clock in the morning and get a disposition for this child was incredibly helpful.
Well, that's great to know.
Will you tell us more about, in this scenario we have here in front of us, this may be a child that has some kind of intermediate risk. I guess we don't know that for sure, but she's not showing cardiovascular collapse. We probably have a little bit of time. I worry about making these complex decisions in children who are like collapsing in front of us. They have high risk pulmonary embolism. They have real shock, real cardiovascular collapse. How have you found to coordinate the communication that's necessary for the multidisciplinary care in managing patients like that? I imagine it's really difficult to do.
You're correct. I think it took us a while to fine-tune our pathway and our processes. I think the way I think about PE management, it's complex, it's time-sensitive, and just multidisciplinary by nature. And so the main advantage of a pulmonary embolism response team or a PERT is that we just centralize expertise and standardize evaluation and then really make individualized decisions. So if I focus on your question, there have been so far 3 to 4 instances where the patient was very sick and crashing, and it was all hands on deck. I think as we were on a call, our anesthesiologist was heading to the emergency department to look at that patient in real time and give us his assessment, because one key aspect is if we need to intervene and go towards a reperfusion therapy, is it sedation, anesthesia? Can the patient lie flat? And at the same time, I think cardiology fellow is running down. If ED has not already put a POCUS onto the chest and gave us a preliminary assessment of the RV, those 3 or 4 instances have been very stressful. And at the same time, I think some team members got off the call and tried to arrange an OR because we determined quickly that the patient really needed to go. We didn't have time to take the child to the interventional radiology suite, and they needed to go to the OR for a surgical embolectomy. So it's definitely nerve-wracking. And I know our adult PERT leaders or PERT teams deal with this maybe once every week. And I'm happy to just deal with that once a year and take care of more stable patients.
From the ICU perspective here, I mean, it's it's very tempting to just focus on the patient in front of you and the Zoom call or whatever's happening in the background. But this is a clear example of this child needs definitive care if they're going to be able to survive this pulmonary embolism. And we have to figure out a way in our teams to coordinate taking care of the patient, the ABCs, but also coordinate with the larger group to how we can get this child the therapy that they need. Now, I would imagine that PE response teams has not been going on for a very long time in pediatrics. With what information we do have, what changes have we noticed in therapies offered to kids with pulmonary embolism if they have access to something like a PE response team?
Yeah, at our institution, PERT implementation led to faster echo times. I think access to echo in real time, as well as faster echo times, faster anticoagulation. And, the point you made, the access to reperfusion therapy, I think we had, in our publication in which we published our experience, we looked at pre-PERT and post-PERT eras. And despite several patients were eligible for reperfusion therapies, I think were treated with anticoagulation. They obviously did well, but as we've looked at their long-term outcomes, we don't know whether removing that clot upfront may have beneficial in the long term, although in the short term, they did okay. So in terms of outcomes of mortality, I think one thing we have to realize is that P-specific mortality in kids still rare. So in order for us to study that systematically, we would need thousands of patients to see a change in mortality. And definitely, I think our PERT inception cohort study will go on for many decades. And after a while, we will be able to answer this question. But as of now, we don't have data to say whether it's impacted mortality, for example.
Oh, well, that's fair. And a great point about you also want that RV to work well for the rest of the child's life, right? They got a lot of years to put on it. So how do you protect that? Okay, so if I'm remembering correctly, you're sort of choosing between systemic anticoagulation to prevent clot extension, systemic TPA, catheter-directed TPA, catheter-directed embolectomy, and then like a full open surgical thrombectomy.
Yes.
Is that correct? Those are the interventions that you guys discussed starting with your PERT meeting?
Yes.
In your 2025 How I Treat article, you have a really nice flow chart, really saying exactly when you do each intervention. Can you walk us through your process there?
Yes. The article makes it seem fairly straightforward in real life. It is a little more complex than that. I think it all depends on your hemodynamic stability, bleeding risk in that child, speed of access to either the IR suite or the cath lab, and then I think who's on and the local expertise. At our institution, a lot of these interventions are done by interventional radiology that may be different in different institutions. I am helping a few other institutions help implement their PERT, and there I've learned it's all done by interventional cardiology, and interventional radiology is sort of more DVT type of interventions. So I think even though in our paper, I think conceptually there's all of this thought process about what to choose, but in real life, it's very, very nuanced. I think depending on how sick the patient is, from my vantage point, systemic thrombolysis is often the fastest. And that is something we can even start. I know we think about starting anticoagulation and then getting them to reperfusion, but more lately in very sick patients, especially the intermediate high, where there's even higher risk features, like maybe on echo, their LV is underfilled. We know that this patient is going downhill. We have done systemic thrombolysis en route to the cardiac cath unit, for example. Again, a half-life is so short that you can just turn it off 10, 15, 20 minutes before whatever the intervention is. I'll try to give you a straightforward answer, but it's always gray. So to me, anticoagulation and then systemic thrombolysis is what will start right away while figuring out some of these practical logistical things, who's on, where can we get this patient to fastest.
And in a patient who's intermediate high or high risk, meaning that for intermediate high, their RV looks bad on echo and the biomarkers, they're coming back elevated, it's impacted. Would you say that you like all of those kids? The ED, as soon as that CTA read is back, they're ordering the heparin drip and then also we're considering ordering the TPA. It's don't wait until your echo and cardiac biomarkers are done in case you should do TPA instead of heparin, right?
Yes. ED will often wait on the PERT team to pull the plug on the systemic thrombol TPA. But I think what we have done through a lot of education is don't wait for the PERT meeting, start the heparin immediately, and then we empower them, but they usually will wait for us to make that decision.
Yeah.
Dr. Zia, please correct me if I'm not saying something correctly here. So it seems like all these patients, when they're diagnosed with pulmonary embolism, unless there's a really severe contraindication, they're all getting heparin.
Correct.
And then you're starting this multidisciplinary meeting, and the results of that meeting are really going to be determined on what resources are available and what are the nuances about this child's clot and physiology. It seems like there's some intuition that getting that clot out might have long-term benefits, but maybe we don't know that for sure. You know, if a child has bleeding concerns, like maybe recent surgery or maybe even trauma in the recent past few weeks, that might make you lean away from something like systemic thrombolytics and maybe more focus on a procedural clot removal. But outside of that, this is something that's incredibly nuanced, and it's really hard to put it in a flow chart.
Yeah, I would agree with that. But I think the way you summarized it from a bleeding risk perspective, yes, that's exactly how we approach it, and may favor catheter-based interventions over systemic TPA in those with higher bleeding risk.
And TPA, is that the drug that's commonly used here, or other options?
Yeah, we use TPA or alteplase. Generally, that's our drug of choice here.
What about our case? She's a gymnast. She's falling at practice, but no recent surgeries, might be on her period.
Yeah. So I think in this case, at our institution, depending on the location of the embolic burden, if it's more central, we would favor a catheter-based approach. And there are no other comorbidities, there are no bleeding risks. And then I think for this patient, she may, at our institution, end up getting a catheter-based intervention. And the other important thing, I know there's limb swelling as well. I think we kind of stage the clot, if you will, because, my training is hematology oncology, and we're so used to staging tumors. And so we do stage the clot as well as what I say, look at the entire clot burden and then decide, obviously, PE or embolic burden takes priority. But with interventional radiology in such a case, if there is extensive DVT as well, and maybe something like an anatomic predisposition like a May-Thurner, which needs to be fixed as well, then this patient overall is better suited with interventional radiology. Because then in the planning phase, they can also make a plan to tackle the leg DVT, put a stent in. So again, that's where sort of that nuance comes in.
So it's easy to see that if you have a patient that's perhaps intermediate risk, where they don't have significant hemodynamic consequences, so you think you have some time, an interventional radiology type approach where you can remove the clot makes a lot of sense. I would imagine, and please tell me how you see this, if you have these children with high-risk pulmonary embolism who have, cardiovascular collapse, perhaps they're needing to be cannulated on ECMO, it seems like those kids might end up going for more surgical embolectomies. Is that correct, or am I mistaken there?
Not necessarily. I think we have had a handful of PE patients that went on ECMO in the past 5 years or so. I think we will prefer to cannulate them for ECMO, stabilize them, and then make the decision about what's the PE intervention that we have to do. So it took us a while to sort of fine-tune that, because we've had a patient that needed to go on ECMO during an intervention. And then we learned from that patient. And I think there were questions whether it should happen first or after. And then through that case, we learned that it's better to stabilize the patient, which probably is intuitively makes a whole lot of sense to intensivists. And so I think now we want to stabilize the patient, cannulate them from ECMO, and then decide, what kind of catheter-based intervention are we doing?
That makes sense too, because VA ECMO would let you decompress the RV and hopefully send some good coronary perfusion, right?
But I think at the same time, as intensivists, we want to support patients, but we also want to minimize morbidity. And I think it's a trap you can get caught in there if you think, all right, they have a pulmonary embolism. If I can get them to the IR suite, they're going to remove the clot and this kid's going to be fine. But still, we have to take an ABC approach, right? And, airway, breathing, circulation always falls well above, clot removal, interventional radiology procedures.
And Dr. Hodges, that was exactly our thought process initially, that we just need to relieve the RV, get those pressures down, and it's going to be okay. But I think we learned that ABC approach that you're referring to, that patient's best interest is to do that first.
Before we move on, Dr. Zia, you mentioned May-Thurner syndrome, which is just something that I was not aware of prior to fellowship. And I just want to give you the opportunity to define that for listeners.
Yes. So it's an anatomic variation, if you will, in which your iliac artery overrides the iliac vein and compresses the vessel. And so it's thought to occur in the second or third decade. Or definitely, I don't take care of patients in the second and third decade, so I see it a lot in my teenagers. There is a predilection for young females to be diagnosed with May-Thurner, but we've certainly seen our share in adolescent males as well. It's important to diagnose it because you could treat that DVT with anticoagulation or even a catheter-based intervention if it's extensive DVT. But if you don't correct the May-Thurner by putting in a stent, which keeps that vein open, there is a high chance of recurrence. And then the consequences of recurrent DVT is the lifelong chronic pain syndrome called post-thrombotic syndrome. And so we like to diagnose that upfront. During the acute DVT, it's sometimes difficult, but our radiologists are excellent at it. And generally, you do see signs of chronic DVT in May-Thurner patients. So often the DVT that they present with is not really the acute. It's more like an acute and chronic DVT. And from imaging, our radiologists are able to tell us that. Usually there's collateralization around the iliacs. And there is evidence when they go to sort of remove that clot, they can tell the clot is not 100% new. And so there are several ways that they will diagnose. And then upfront, they'll put a stent in as well.
Oh, that's wonderful. Thinking about that lifelong clot risk is so important. I have a question, Dr. Zia. As the person who leads the PERT team, reviews all the pulmonary embolisms, even though you're a hematologist and these things are not your problem, I'm wondering if you have any thoughts on the cadence of adding a little nasal cannula oxygen for pulmonary vasodilation, putting the patient on nitric, or even the decision to intubate.
I'll take a stab at it. I think that is where the beauty of PERT lies, because that's where our intensivists are part of it. And this will not come naturally to me, the things that you mentioned. That's where they'll add in their management piece and say, why don't we do this? Why don't we protect the RV or support the RV in this way? So often I hear those, and obviously I learn from that. And as I'm helping some of the other institutions, I will mention that, hey, having an intensivist will help you with XYZ. So I do not propose those, but our intensivist colleagues certainly do. And it's just better for the patient because we're looking at the patient just in a very holistic manner.
Alice, I think you've found a reason for a part two in pulmonary embolism care.
Excellent.
So stay tuned for that.
Yeah. I will share that having anesthesiology as part of the PERT team has been, I think, one of the most critical piece of our PERT as well, because not a lot of PERTs, even adult PERTs, have that. And I think our PERT member, who's an anesthesiologist, has the best questions for us, and he's always encouraging us to really focus on some things that we, again, the hematologist, the intensivist, or the interventional radiologist may not be thinking about. And I think the choice of anesthetic or the medicine for the procedures, I think, is something that's dictated by them and also very helpful.
Yeah, and if I'm not mistaken, like so many of these IR procedures, they may even get like popliteal access. So you might have to prone this patient, during the case, and there might be reasons you can't get that done. So, having everyone that's going to be involved in this child's care on these conferences, I imagine, is incredibly helpful. So, Dr. Zia, we've taken this difficult topic of pulmonary embolism, and we've tried to grill you with these questions. What would you do in these very high risk scenarios where there's lots of clinical nuance? And you've done a great job navigating that, and we appreciate you sharing your expertise with us. What do you feel are pitfalls in either the diagnosis or the management of PE in kids that you'd like to emphasize for us?
Yeah, I think failing to consider PE in a child or an adolescent would be one, over-relying on normal vital signs, delaying anticoagulation, and really not setting up your long-term follow-up pathways, whether they are with hematology or pulmonology. I think those are common contributors to poor outcomes in PE.
Wonderful. So as we move towards the end of today's conversation, we of course wanted to thank you again for joining us. What do you feel like are the most important unanswered questions in this space, or what else would you like to emphasize for our listeners?
Yeah, I would say the intermediate risk category is one where we just don't know a lot about. Does intermediate low eventually become intermediate high? Because I can tell you that even intermediate risk high, there's a spectrum. And so right now we consider it one category and will decide to escalate beyond anticoagulation, but not all of them require that escalation, how to choose who to do that for. I think that is one area. And really there are no interventional trials or clinical trials in the acute management of PE. Like there's nothing in that space. So I find that is one area, as folks listening, if they're really passionate about PE research, that is one area where it's an untapped area.
Oh, wonderful. Well, Dr. Ayesha Zia, thank you so much for joining us today.
Of course, the pleasure was all mine.